only really an atrial signal timed with the P wave, which I'm going to just click and show. Then you have to, in your head, imagine, and I'm going to show you.
I think it's a common tendency of fellows to, but the master calls electrophysiologic evaluations. And
A lot of the concepts in the workshops we're sort of covering, and one of the things that you should keep in mind, particularly those second-year cardiology fellows who are going to be applying in the EP match, take note not just of who's speaking at this meeting, but where they're from, because recognize that all of the people presenting at this conference could potentially be your mentor. If you decide to apply to EP programs, say, oh, let me go look at that last page of the program and see what program they're from. And maybe say, oh, I didn't even think to apply there, but maybe I will, because they would be a wonderful person to learn from. That, of course, includes our program at Temple, so please apply to our EP program too. But seriously, for everybody, I mean, this is a combination of a lot of really wonderful teachers. People are here invited because they're good teachers. They attend because they enjoy teaching. Leverage that and recognize for those people who are not committed or be looking next year for a spot, pick and choose who you think would be good to work with, and maybe that's a factor when you apply for the match. All right, let's talk about EP studies, et cetera, and pick up where we left off earlier. I wanted to show first a couple examples of intracardiac recordings. Let me grab my pointer. See if it works. Yes, it does. So we're going to focus on this catheter here, which is positioned in the His position. Even though this happens to be a decapolar catheter, usually we use a quad in that position, but here it happens to be a deca. And I'm going to show you 5 different electrograms recorded from these 5 bipoles, just to give you a sense of the field of view and the types of recordings that we're getting in the heart. So you have to, in your head, imagine the AV groove is going to be somewhere around here, with, in this RAO view, the right ventricle being over here and the right atrium being over here. And actually, I'm going to just click and show the next components here. Notice that in just this short distance, we go from a bipole that's recording here on the left only really atrial signal timed with the P wave. Sorry for my tremor, it's one of my medications. And there's a little far field signal that times with the QRS, but we're on the atrial side of the annulus, so we're only recording an atrial signal here. But if you go just one pair of electrodes further, we get a smaller A, more V, and now you can see a bundle of His recording in between the two. If you go a little further, you see even less A, and you still see a little His and a bigger ventricular signal. So just in this short distance, you can see the change in the field of view of the electrograms that you're recording right at the annulus. And further down, you see a right bundle potential and ventricular signal with no atrial, and further down, just ventricular signal and no bundle recording. We talked about being able to measure intervals inside the heart, and just to review this is pretty basic, but just to, again, bring everybody up to speed, including those who have not seen these before. Here is just simple recordings from in the heart. The top 3 are obviously the EKG leads. Anything that lines up with the P wave is an atrial signal. Anything that lines up with the QRS is a ventricular signal. And anything that's in between in the PR segment is neither, and in this case, it's a His recording. And this allows us, as I said earlier, to break apart the PR interval into its 2 components, the AV node part and the His-Purkinje part. And the only way we can do that is by recording this intracardiac His that you can't see on the surface EKG. So, I don't know why I struggle with this clicker. Here we go. As signals travel from atrium to ventricle, of course, you're going to pass through the AV node to the His. Now, the AV node is made of tissue where the fibers are not oriented in the same direction. There is stroma between the myocytes. The conduction through the AV node is disorganized and slow and multidirectional. And therefore, even with an intracardiac recording, we don't record an electrical signal of the AV node. We can record atrial signal nearby. We can record the His bundle just after the AV node, but not the AV node itself. So how can you measure how long it takes to get through the AV node? And the answer is, well, if we can take, looking at the picture up here, record the atrial tissue signal from right near the AV node, and we can record the signal in the His just below the AV node and measure the timing between them. That's how long it took by inference to get through the AV node. Notice I didn't say that we use the HRA signal. I don't want to know the sum total of time it takes to get from the sinus node to the AV node and through it to the His. I just want to isolate the AV node part. So when we're making the AH measurement, we will do it using the atrial signal that's nearby the AV node in the His catheter. So you measure from the atrial electrogram in the His catheter to the His bundle recording itself, and that is the time it takes to get through the AV node. How do you measure how long it takes to get from down the His-Purkinje system? Well, the start is the His bundle. The end is the start of the surface QRS. And so that's the HV interval. I didn't really show, what I should have done is put a vertical caliper here. The right caliper really should be at the very start of the QRS on the surface EKG. Wherever you reach the ventricle first is where the HV interval ends. So these are the standard measurements that are part of every EP study that you should learn to make, and the reason why we measure it at those locations, the AH and the HV. Okay. Let's look at a few intracardiac recordings to get those who are not familiar with these as much more familiarized and comfortable. I'm showing them in color because for me, adding the color element helps organize things and see patterns better. And I will orient these all in the same sequence for the next series of slides. This is what a sinus beat looks like with intracardiac recordings. How do I know it's a sinus beat? Several reasons. If you looked at all 12 leads, and on the first page of the recording system, you have all 12 leads. Now only 3 of them are displayed up top. The P wave is upright in lead 1, it's upright in AVF, it's biphasic in V1. It's stretched out, so it's hard to see that shape, so you could compress it and look at it at 25 millimeters per second, or you could gain up each of these to see the P wave better. But those are tricks that you'll learn to manipulate the EKG. But importantly, if you look at the activation sequence in the catheters, as we discussed earlier, high right atrial catheter, His catheter, CS catheter, you're going to see a sequence where the HRA catheter is going to be first during sinus rhythm if it's positioned near the sinus node, which was a really good point that Furman made earlier, which is you can label these however you want, but if they're not in the positions or they're hooked up wrong, then you're going to have misleading information. So one thing to keep in mind is always be sure that your labels are accurate, your catheters are plugged in right, and they're positioned in the heart where you intend. Sometimes the HRA catheter slips during cardiac motion and breathing, and it falls over toward the His bundle, and you see a His bundle recording on the HRA catheter. It's out of place. But you see the beginning of the signal during the beginning of the P wave is first in the HRA. It traverses the right atrium. You then see the atrial signal in the middle of the heart where the His catheter is positioned, and then it travels right to left out the left atrium parallel to the coronary sinus, and so you see these atrial signals in the CS after that. Why did I number these with CS 1, 2 at the bottom and 9, 10 at the top? It doesn't seem elegant from a numerical perspective, and many people will reverse it because they're uncomfortable going out of numerical sequence. For me, it makes sense for a sinus beat to go from left to right, top to bottom. So I position the electrograms, you can shift them however you want, such that 9, 10 is on top, so that during sinus rhythm, the beat is in the sequence that is consistent with the rest that's on the page, top to bottom, left to right. I'm just going to grab my other laser pointer. Sorry, one moment. This one is on the fritz. and then you see the His bundle recording, and then you see electrograms. Notice the far-field electrograms in the CS catheter. The coronary sinus runs in the groove between the left atrium and the left ventricle. Sometimes it usually rides more on the atrial side of the groove. So usually you see very sharp, nice atrial signals and less ventricular, but sometimes everybody's different, as was said earlier as well. You may see sharper ventricular signals, especially as you get further out toward the great cardiac vein. This venous structure deviates toward the ventricle and away from the groove, so you start to see taller ventricular signals the further out you get. If you pushed it further out the great cardiac vein, you're going to see even bigger ventricular signals. But you know these are ventricular because they line up with the QRS.
Here.
Yeah.
Why there's no fragmented signal over the AV node due to anisotropic conduction?
Yeah, in order to generate a signal that we can record that is of a frequency that's in our range that we're looking for, and that is of sufficient amplitude, you need to have enough myocytes that are being depolarized in the same direction at the same time to generate a signal that is of sufficient amplitude to record. And in the AV node, because of the slower conduction and the sort of lack of parallel structure of the myocytes, the vectors are different. There are fewer cells being activated in any region at any given time, is, I think, anatomically the reason that the signal that's generated is just not large enough and simultaneous enough for us to record with our current technology. There may be ways in the future to do that, but with the electrodes we have right now, and the amplification and trying to get rid of noise, we just can't record it.
Do you think the slow pathway potential, as you're doing slow pathway ablations, may represent anisotropic conduction?
Interestingly, I'm not sure personally that I've seen a signal that I'm convinced is a slow pathway signal, but there's no question that in the little isthmus between sort of in front of the coronary sinus and above the tricuspid annulus, this corridor, as we'll talk about tomorrow, that is where the slow pathway is located, it may be that the reason people see this sort of slow pathway potential may have to do with the cells are more aligned, or there's a more coordination of electrical systole in that area, and maybe that allows us to record it with our electrodes. I don't know if you have...
Well, it's controversial. Nobody really knows. Josh will go over tomorrow, but to get to something non-controversial, 2 questions. Why do you measure the earliest ventricular activation from the surface EKG? Why is it never measured from the intracardiacs?
Yeah, and it can be either. So the point is you're trying to measure the time from the His bundle to the first branch of your His-Purkinje tree that hits myocardium. Where is that going to be? And am I going to have a catheter at that spot? Probably not. It may be in the left ventricle where you don't even have a catheter. It may be somewhere in the right ventricle, which is not where your right ventricular apical catheter happens to be positioned. So the chances are low that you're going to happen to have an electrode right at the first place where the Purkinje fibers break out into ventricular myocardium. That said, maybe you got lucky and you may see a signal in your ventricular catheter just before the surface QRS starts, in which case I would actually measure to that signal. But you want to measure to the first ventricular event, which is usually the very onset of the surface QRS, which really does summate all of the ventricular myocardium, not just the little local areas where our bipoles are sampling.
Yeah, it's a common mistake and assumes particular importance when you're looking at VA times. You always measure it from the first ventricular activity on the surface or intracardiac. It's almost always on the surface.
And then finally, sometimes, why does Murgatroyd say to measure the AH interval by taking the peak of the first deflection and not the beginning of the atrial signal on the His catheter? So peak versus...
Fair enough. So that gets into the question of a bipolar recording and really what part of that multi-deflection signal represents local activation time. And truth be told, whoever asked that is spot on, that really the local activation time is the first sharp deflection rather than the onset of the bipolar recording. So you probably should take the sharp initial deflection, not the upslope or the downslope of that recording, but the sharp deflection is really when the wavefront is passing between those two electrodes. But you do want to use the signal right in the His catheter so that you're recording local atrium just above the AV node right nearby and not somewhere else. So you're adding in transatrial conduction time into that measurement.
Yeah, so another good question. These are terrific questions. They're really important, basic questions that a lot of fellows don't ask, so keep them coming. In the CS, when you get a sharp signal on the V, like you don't have here,
Yeah.
what does it tell you about the location of your catheter relative to the LV? This is an important concept.
It's a great question.
Yeah.
And the point remains that sharp signals indicate that the bipole is near that tissue from which you're recording. So if you're recording a sharp ventricular signal, it suggests that that bipole is close to or overlying ventricular tissue. How could that be? Well, there are a couple different scenarios where you might encounter that. Number one is if you advance the catheter further out the coronary sinus, as I said earlier, to a portion of the coronary sinus great cardiac vein system that is now veering away from the left atrium and toward the left ventricle, now that venous structure is more ventricular. That's one scenario. Another is you accidentally advanced the coronary sinus catheter down a vein branch that branches off of the coronary sinus and heads toward the ventricle, in which case you'd see only ventricular sharp signals and no atrial signal, which is a sign you need to use fluoroscopy or ice and reposition that catheter so you don't perforate or puncture that vein. And a third is that most of us nowadays put a catheter in the coronary sinus from the groin, where we go up to the right atrium, deflect it, and it tends to ride on the roof of the coronary sinus, which is a little bit more atrial. But in the older days, and still now, many people will insert from the internal jugular vein a coronary sinus catheter, and then it travels down to the right atrium and travels on the floor of the coronary sinus, which tends to be more ventricular. So you might have more ventricular signal depending on the approach to the coronary sinus.
So how do you recognize the right bundle potential?
So yeah, I made that mention and I passed over it, but thank you for asking. So we know that in humans, the His-Purkinje system, and in all animals, tends to conduct at pretty predictable fixed rates. So the HV interval almost always is in the 40 to 60 millisecond time frame. If you were to record an HV interval that's short, 25 milliseconds, there are a couple possibilities, as I'm going to review in a few slides, but one possibility is that that's not a His recording. You advanced your catheter further downstream and you're recording a right bundle potential. So it's a right bundle to ventricular timing of 25 milliseconds rather than His. And another clue is, of course, the more you veer away from the annulus, you're going to see no atrial signal at all. So the combination of seeing an atrial signal in the His catheter and measuring an HV interval that is physiologic in the range that we would expect tells you that it's likely a His bundle recording. If you don't see an A and this interval gets shorter, this is later, suggests that you may have advanced the catheter and you're recording from further downstream, closer to where it exits to the ventricle. Okay. Quiz time. So, there are 2 beats on this page. And now from everything we've discussed, you have to tell me what these beats represent. And you can do either beat first. This is the yell it out, don't text it to your iPad. I have to be able to hear it up here to tell you if you're right or not. And I hear murmurings. I hear ventricular retrograde conduction. So which beat are you referring to? The first beat. And that would imply that that beat is a PVC. And why do you say that? So there are several steps. The way I would methodically go through it is the first thing that I would say is the ventricular events precede the atrial events. That sounds simple, but until you start thinking logically like this, when you get into more complex scenarios, you're going to be thankful that you think it through this way. Well, how do I know if I look at this mess here in the His catheter? There's 2 or 3 different things in there. How do I know that this is not A and V versus V and A? So number 1 is you look at the surface EKG, and you see up here a wider beat than over here. Is that a P wave in front of this? No. How do you know it's not a P wave? Because there's no atrial signals anywhere that line up with that thing. What is that? It's the T wave from the beat that's off the screen, because it looks like this thing, and there's no signals that correspond to the T wave on the intracardiac recordings. So number 1, and as Furman said, go to the surface EKG, or maybe Sam said this. It's very important to appreciate the surface EKG first. So look at this. There's a P and a narrower QRS. There's a wider QRS with no P in front of it. And then you go to the intracardiac recordings. How do I know that these are atrial signals and not ventricular signals? Because they kind of it sort of lines up with the V, maybe. They're sharp, but, well, I don't know. Maybe I went down a branch of the coronary sinus. Maybe it's advanced out to the great cardiac vein.
Same activation sequence of shape as the one on the right?
So the answer is you need to compare it with this beat. That's a more predictable beat. This is a sinus beat on the right because it looks exactly the same as the last slide. It has the activation sequence. It's earliest in HRA. It has the AH, the HV. Everything lines up. So it's always helpful to compare a beat to sinus. I would disagree, though, about the activation sequence and the morphology. I think these electrograms do look a little different in their shape, which, is a subtle thing. We'll get to activation sequence in a moment. But the fact that we have sharp signals here that line up with a P wave, that very highly suggests that on an adjacent beat, the sharp signals are also atrial signals. This catheter didn't wildly go to a new place between beat 1 and beat 2. So if you can say with certainty here that these are atrial signals, and you see them over here, they're atrial signals there. This gets especially important when atrial and ventricular signals are overlapping, like in AV node reentry, as we'll see tomorrow, like in a PVC that happens on top of a P wave, in those types of scenarios. So get used to figuring out what you know and then extrapolate to what you're not sure. So the fact that you see sharp signals here suggests A. Getting to the other point that was mentioned, though, the activation sequence, that's the second part of this question. So that's a PVC. Is this atrial event a sinus beat, or is it retrograde activation? I heard people say retrograde activation, and the question is, how do you know that? Because you could have a PVC happen that doesn't conduct retrogradely, and there happens to be a sinus beat there. So concentric activation is a term that suggests that in the coronary sinus catheter, you're going 9-10 out to 1-2. You're going right to left in that catheter. Okay? So in sinus rhythm, everyone agrees that, yes, that's the direction you'd expect the wavefront to propagate, from right atrium across the right atrium, then across the left atrium. But during retrograde activation, where you have a ventricular beat, paced or spontaneous, that comes up the His-Purkinje system through the AV node. Where's the AV node located? Smack in the center of the heart. And then which direction in the atrium does it go? Both directions. It goes left to right in the right atrium, but it goes right to left in the left atrium, right? It doesn't, the AV node isn't on the other side of the coronary sinus. It's on the right atrial side, septal side of where your coronary sinus catheter is located. So during retrograde conduction through the AV node, you are also going to get concentric activation in the coronary sinus, because it's going to come up the center of the heart. It's not coming from the high right atrium, but it's going to come up the center of the heart, and it's still going to go 9-10 to 1-2. So the sequence in the coronary sinus in both cases will be concentric, and that will not distinguish a sinus beat from a retrograde beat coming over the AV node. So I heard that the hiss is coming before it, but that's true in sinus also. The hiss comes before. The HRA is the answer. right? There's only one electrode here that tells you that there's a different activation sequence in this atrial beat compared with this one. Here in sinus, the HRA is early. Here it's late. So this can't possibly be coming from the sinus node because the electrode pair that's closest to the sinus node is activated late. So this is a retrogradely conducted beat from the PVC through the AV node and then going in both directions. Yes, it activates the His early, but you'd expect that here and you'd also expect it here. Yes, it's concentric in both cases, but that's the key. Some people do EP studies without a high right atrial catheter. It's one more catheter. It's helpful sometimes, especially early on. All right? So is there anything, I know we went through that in a lot of detail, but I think it's really important as you are building a foundation. And if we don't get through all my slides, who cares? The point here is to just get familiar with looking at these recordings. I'm going to skip that, and I'm going to go to this one, and we'll cover a couple more things, and we won't cover all my stuff, but that's okay. 2 beats. What about these 2 beats? Can you tell me? What are they? I hear different atrial activation. The first one is an ectopic atrial beat, and you say that because?
The very first activation is on 3/4.
Again, it's all about the atrial activation sequence. So the second beat, again, is a sinus beat, which serves as a nice comparison. But what happens first? We have activation over here. So not only can you tell me that this is an ectopic atrial beat, what more can you tell me about its origin? It's from the left atrium.
But where on the left atrium?
Septum or lateral wall?
High or low? And why?
That is a great question. Is it the roof of the left atrium or the floor of the left atrium lateral? Why do you say that? So there's one, and why would the HRA timing differ whether it came from the ceiling of the left atrium or the floor? But it's higher over on the right side, so it's true that if Bachman's bundle delivered signals quickly from left to right atrium, but everyone's a little different in how their atria connect. There's another really key point that gets us back to basics. What were you going to say?
The A on the His is activated before the HRA.
The A on the His is activated before the HRA, which is not surprising if you have a signal coming from the left atrium to the septum, where the His is, and then to the lateral right atrium. So you might see that in either case. Yeah. What do you see about the P wave shape? Here in sinus, AVF has an upright P. Maybe it's sort of upside down. If it's inverted, it suggests a superior vector, which is a really, really good point. Never forget the surface EKG. It gives you additional information that we couldn't get from the intracardiac recordings. We only have 5 electrodes, pairs of electrodes on the floor of the left atrium. We don't have any electrodes on the roof of the left atrium for a time comparison, but we have a surface EKG that looks at the whole of both atria. It's a really, really good point.
Can you make that same assumption based off the vector of the HRA?
No. The vector of so these are all bipolar recordings, and you can't say anything about them by their shape other than the few issues I pointed out earlier in terms of if there's a change, it means the wavefront is different, but it doesn't tell you where it's coming from. A negative versus a positive deflection really has no specific directional meaning with a bipolar recording. I'm going to go a little bit faster through a couple slides.
Josh, why don't we do this? Why don't we work these through and put the workshops on hold? Because
Okay.
this stuff is really important. This is the basics, and you're doing a great job with it. So we'll
right.
forego take what time you need. I
Yeah.
think. Yeah.
Sorry, I think this year I'm even slower and more verbose than usual. If that's possible. Yeah, thanks. I don't know what just
Till
give me
4:30?
like a signal that it's time for me to shut up, and then I won't go too much longer because there's only so much you can absorb in a day. But I do think it is important to try to understand these basics, because you're going to see the rest of this conference, it's going to be these electrograms, and if we don't kind of get these concepts now, it's, you know, you're not going to be able to pick up quite as much later on. I wanted to show, again, the benefit of His bundle recording in the context of surface EKG and intracardiac recording correlation. So here is Wenckebach. We know this because we see a prolonging PR interval, and then we have a P wave with no QRS, and then after the pause, the PR interval shortens again. And the equivalent of that inside the heart looks like this. And to help you organize, can you see all the, now instead of showing you 1 or 2 beats, there's 5 beats. And what belongs to what. So I'm going to help you. In the future, you won't need any help at all. But if I group them and I show you where the boundaries of each beat are, now you can start to say, okay, well, that times with the P wave, that's an A, that's a His, that's a V. In fact, I'll help you there too. I'll label the A, H, and V. So notice as the PR is prolonging, what part of the His bundle recording is changing? The AH interval, right? It's getting longer. And that's, I mean, to you now that's obvious because you know that Wenckebach suggests delay and block in the AV node. How do you know that? You know that because we owe a great debt to the electrophysiologists who used to practice before pacemakers and defibrillators and before catheter ablation existed. So you ask yourself, what the heck did they do with their time? And the answer is they did this all day. They gave drugs and they put catheters to record the His bundle and they paced. That was EP. It was unpopular back then because you didn't do very much. But we learned so much from what they did, to the point where they so exhaustively understood how the electrical system of the heart worked that we take it for granted. So when someone says Wenckebach, you say AV node. Why? Because they did this recording and they saw that the AH interval is the element that was prolonging during a Wenckebach cycle, thereby defining the point of slowing and failure at the level of the AV node. And they saw that over and over and over. And similarly, when you had Mobitz 2 block like this, where you had a P wave without a QRS that was unpredictable, and the QRSs that conducted were wide with fascicular and bundle branch blocks, they recorded this. They saw a His bundle there, but no V. So the signal got through the AV node, no problem, to the His bundle, but then at the distal His or somewhere in the Purkinje tree, that's where the point of blockage occurred, and you didn't see it. So now we know if you see a Mobitz 2 pattern, that suggests His-Purkinje disease. Very different treatment implications. AV node block, asymptomatic, maybe not urgent, maybe not need treatment at all. His-Purkinje disease, emergency. They could at any point completely fail with their His-Purkinje system and have asystole or a prolonged pause resulting in syncope or worse, and they need a pacemaker. Clickety-click. I'm going to skip this slide because it's sort of redundant. I am going to skip this slide, I think. I just want to see what I have next. Forgive me for passing this for a moment. Oh, yes, because I wanted to discuss pacing. I knew I had to get to something. So pacing maneuvers that we do, and Sam talked about this, so I'll go through actually this slide pretty quickly, but we will do pacing maneuvers during sinus rhythm to assess the conduction system and to try, including sinus node and AV connections, and to try to induce arrhythmias. And then during tachycardia, we do it to try to figure out what is the mechanism and location of the tachycardia. Terminology. So we talk about burst pacing, and we talk about programmed extra stimulation, which is abbreviated PES frequently. Burst pacing means that from one pair of electrodes, you're going to deliver a sequence of pulses all at the same rate or the same cycle length. That's called delivering a burst for whatever number of beats. Programmed stimulation is pretty formulaic. Usually people will deliver 8 beats at one particular rate, usually 600 milliseconds, which is 100 beats per minute, or 400 milliseconds, which is 150 beats per minute, for 8 beats in a row to create a very stable, predictable electrical environment. And then we put in early beats thereafter. And this is what it would look like. There are your 8 beats, and you can put in 1 or 2 or 3 premature beats of shorter coupling intervals. The terminology here is the 8 beats of the what's called drive train are all known as S1, or that's first cycle length. S1, 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 S1. If it's in the atrium that you're pacing, people may call it A1, A1, A1. If it's in the ventricle, V1, V1, V1. When you put in a single early beat, it's called S2 or A2 or V2. And the next one is S3 and S4. Usually people don't do more than 3 extra stimuli nowadays during an EP study. And you're often doing this to try to provoke an arrhythmia or look at for a refractory period. You're shortening and shortening and shortening the 1 or 2 or 3 extra beats, waiting till you reach a point where you can no longer capture because you've met the refractory period of whatever tissue you're pacing or through which you're conducting. Or you're looking to initiate a reentry circuit by bringing a beat in so that you block in one limb of the circuit and conduct down the other and thereby initiate reentry through unidirectional block, which we'll talk more about tomorrow. There's a concept called sinus node recovery time where you burst pace in the atrium for 30 seconds and you come off and you wait and see how long it takes the sinus node to recover. Nowadays, we don't do this too often. Why? Because of sophisticated, easy access, long-term recording systems. If someone has presyncope or syncope, whether it's with a Holter monitor or an implantable loop monitor or their Apple Watch, we almost always can get a recording of the rhythm during symptom. That didn't used to be the case. They didn't have these long-term monitors to catch events that happened less frequently than once per day. And so you had to do EP studies to try to see, does this person have sinus node dysfunction that may be an explanation for their syncope? Their resting heart rate's 48. I don't know, did they have a pause? Let's pace, 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 come off. Does the sinus node leap right back into action, or is there a delay? For example, here in the top, normal sinus node behavior. In the bottom, abnormal sinus node behavior, a long sinus node recovery time. It's a little bit moot. If you can take a recording that someone fainted when they had a long sinus pause, you could reprove it again in the EP lab, or you could go ahead and put in the pacemaker because you've recorded simultaneously the problem with their symptoms. Maybe 1 or 2 more slides and then we'll call it. Here again is programmed stimulation in the atrium. We can see the tail end of the 7th of 8 drivetrain beats. It's the conducted QRS. This A1 is the 8th drivetrain beat, pacing in the atrium, generating a P wave. Here is the first extra stimulus, the A2, at a shorter coupling interval. And I'm going to have you focus on the Hiss catheter recordings. In fact, I'm going to visually erase everything except for one line because that's what I want you to focus on, and you will soon learn to ignore things that you don't need to look at right now, but I'm forcing you to do that now. And first things first, what are these electrograms? It's the pacing artifact, so don't confuse that with an intracardiac recording of atrium or ventricle or Hiss or whatever. And you can see it on the surface as well. So that's pacing artifact, and you can ignore that. We're doing that on purpose. That's from us. Notice the PR on the surface on the extra stimulus has prolonged. Predictable? Yes, the AV node decrements. The faster you hit it, the slower it conducts. That's normal AV node behavior. Here, intracardiac, the equivalent of that, the AH prolonged on that A2 beat, just as you would suspect. The HV did not prolong because you can hit the His-Purkinje system as fast as you want. It conducts at the same speed. It does not have, in general, decremental properties. I'm going to go through this maybe as a last concept. Here, I think I erased things. Let me erase things. Here is, again, a drivetrain of 8 A1s. Here's the last one. And then an A2. And here is the Hiss recording here. So my question to you is, what's happening on that second beat, the first extra stimulus? Here on the first one, we paced. We have, see, on the Hiss bundle recording an atrial signal, a Hiss signal, a ventricular signal. We pace early. And what's happening on that beat? So I hear accessory pathway. Like many things in EP, there's often more than one possibility. I hear PVC. And so what are the notable features of that beat? The QRS looks totally different and it's wider, suggesting we're not using the whole His-Purkinje tree to depolarize the ventricles because it's wider. What if I asked you, is that aberrancy? Why not? There's no Hiss, right? So somehow this wider QRS got generated without going down the Hiss. So aberrancy would have to go down the Hiss before it goes down one of the branches, the right or the left bundle, depending on what form of aberrancy it is. So what generated that ventricular event? And the two possibilities you mentioned are exactly right. Either there was a coincidental PVC that happened to come in at that time and generate that QRS, or we conducted over an accessory pathway. And why does it look so different? So let's say there's an accessory pathway. Why wouldn't this beat look like that? So yeah, so I've heard people say, well, it's going down the AV node, but what if it's going down the AV node here too? So either the AV node is refractory on this beat and this beat is only going down an accessory pathway, or the Hiss is in the V and it's going down, but we decremented so much through the AV node that the contribution from the His-Purkinje system is much less on the second beat than going down the accessory pathway. So we have more pre-excitation on the premature beat. And if you look carefully, there is a little delta wave here. And if I measured the HV from the Hiss to the beginning of the delta wave, it would be short. So this is, in this case, pre-excitation. But notice the difference when you put in an early beat. You have decrement in the AV node, so you have less contribution to the fused QRS from the His-Purkinje system and much more, and maybe completely, from the accessory pathway feeding into, which doesn't decrement usually, into the ventricle.
Josh, a terrific question came in on that. Where is the accessory pathway and why? And the question was submitted by me.
Great. So I'm going to actually go to the next slide of the same patient to show the sinus rhythm EKG in all 12 leads and atrial fast pacing at 320 milliseconds. And the question is, where is the accessory pathway inserting into the ventricles? And I need help because I'm not sure I can answer that myself. So we look at the vector of the QRS and what leads are helpful to figure out. Is it a right-sided pathway? Is it a left-sided pathway? Is it inferior? Is it anterior? What leads are you going to look at? What does V1 tell you? It's a positive deflection, a positive QRS. So this is when you have to remember that our nomenclature for the chambers is not totally accurate. So the right atrium is also the front atrium, and the left atrium is also the back atrium, and V1 sits on the front. So if you have a positive QRS, that means the vector is coming back to front from the left atrium to the right atrium. And this is positive, so that suggests a left atrial or posterior atrial connection or
So
origin.
How do you distinguish between a left free wall and a posterior based on the EKG? This is EKG, guys. You learned this during your cardiology fellowship.
So you have a whole mitral annulus. You could have an accessory pathway at noon, at 3, at 6, at 7. How do you decide where around that circle the connection is?
Let me teach you something I learned in my first year of cardiology fellowship. Take your fist, put it out in front of your left fist, okay? And just put it out like that. The septum is about 45 degrees. So as Josh said, the right atrium is anterior. The left atrium is really posterior. Now tilt it up about 30 to 45 degrees, okay? And right where the thumb is here, that's the os of the coronary sinus. So if it's up 45 degrees and it's a posterior septal, what's going to happen to leads 2, 3, and AVF? The vector's moving away from it. And what's going to happen in 2, 3, and AVF? Negative. What's happening here? Are you positive? Okay. So what does that make it more likely? Left free wall. Okay, so the posterior septals have a characteristic signature of being negative in 3 and AVF. And if you're negative in 2, what does that tell you? Broth, I know you know this. And if nobody else answers, I want to call on you. If you're negative in lead 2 with the surface EKG, with what appears to be an upright QRS complex delta wave in lead V1, anyone know? So that's a signature. Broth, want to help me out here? Yeah. So middle cardiac vein. If you see a negative delta wave, very commonly, and Sonny will probably go over this, it's in the middle cardiac vein, and you need to go into the os of the coronary sinus, many times doing a venogram. Many times there's a small little diverticulum there, and you need to go into that. So this is just thinking about the vector of depolarization. You don't need to go through the algorithms, and you can figure it out just from those vectors. So sorry, Josh, to interrupt.
No,
but
it's
yeah,
perfect.
yeah.
And the last point I want to make as we're thinking about vectors, in addition to seeing that it's going back to front in V1, and then it's going top to bottom in 2 and 3, notice it's totally negative in leads 1 and AVL, which suggests, again, sort of more leftward, sort of a very pronounced left to right vector. So this is sort of a anterolateral left atrium to left ventricle accessory pathway. I think I'll stop there. I have more stuff, but I could talk all night.
Yeah, that's okay. Josh, thank you very much. Terrific. So we let the fundamentals go because these are really the building blocks. And actually, some of the questions that came in were really, really spectacular. Some of them came in that I deferred because I know they're going to be covered tomorrow and on Saturday as well. So this was a great start. We are going to be posting all of these materials, workshop cases, and everything for you. And at this point, we're going to adjourn. There is a innovation center, a reception. There'll be food on the 5th floor. And then we'll regroup here at 6:30. Sam, I think you've got a 3T presentation. So that'll be the first 3T presentation. We'll be down here promptly at 6:30. And then Sam will go through some materials and the cardiac dissections. They'll be changing the room over, so we all should be out of here